Good afternoon and welcome everyone. This is Tuesday, February 16th, 2016, Health IT Lunch and Learn webinar. This education opportunity is offered through our partnership with Georgia High Tech, Georgia's federally funded Health Information Technology Regional Extension Center. And I'm Sherry Ackerman, Project Coordinator for Hometown Health. We certainly thank you for joining us today. The presentation will be on PQRS and will be led by Dr. Adrienne Mims with Alliant Quality. And with her, too, some of you probably know, is her colleague, Donna Cohen. So thank you guys for being here. Also in the background is Mark Renfro, Hometown Health's HIT and Georgia High Tech Lead, a Hometown Support Team, and Carmen Hughes and Yetra Bellamy of Georgia High Tech. And Carmen has an update on the EHR incentive program attestation dates and deadlines, and she'll go over those quickly at the end of the presentation today. So I'm just going to remind you, all attendees are in listen-only mode. We invite you to ask questions through the Q&A box. You'll see at the right of your screen the GoToMeeting panel. Click on that red arrow. That'll expand the box. You can click on the block next to the questions and type your questions and answers, and we'll monitor and answer those as we go through and at the end of the presentation. So here's what you can expect to learn today. You'll be able to determine eligibility in the program, understand how to participate, describe the alignment of the clinical quality measurement requirements for 2016 with other reporting programs, and relate the revised submission deadline and which reporting method it applies to, and understand the penalties and how to avoid them. So if you'd like CEU credit for taking part in the education today, you can take the online quiz within 30 days, pass the assessment, and complete the evaluation. And this is offered free to our Georgia High Tech members. Let me make just a couple of quick announcements from Hometown Health. This is to remind you, we host our Medicaid and Medicare reimbursement update webinars each month. Medicaid is the 2nd, and Medicare is March 9th. We also have on Friday, February 26th, a Security Strategies for IT, a webinar offered by our business partner, Envision. Excuse me. Hometown's annual spring conference will be in Savannah, April 20th through 22nd. And for many on the call today, we'll have the Health IT and Rural Medical Community Network breakout at 1 on Wednesday the 20th. And there's information on that. So we will make the recording from today's presentation available on the Georgia High Tech Online Training Center. So you can go there in about a week. You should receive the email from me with those instructions and the link. And you can find past webinars on the Online Training Center, including such things as Risk Assessment Tool, BYOD, MedRec, and many more. If you have any questions or wish to take advantage of any of the additional fee-for-services offered through Georgia High Tech, please contact the Customer Support Center. Here is the phone number and the email address listed here on the screen. So now let me introduce our presenter, Dr. Adrienne Mims. She's a board certified in family medicine and in geriatric medicine with fellowship status in both specialties. She has more than 30 years of clinical practice experience in caring for Medicare beneficiaries, including hospital, office, nursing home, hospice, and home care. She has a unique insight to the needs of the patient and family members and that of the clinical care team. As a clinical epidemiologist, she has more than 20 years of administrative experience in using quality performance metrics to guide changes in clinical processes, clinician and patient education, and organizational delivery system redesign in small practices, large disease management, Medicare Advantage, and managed care organizations. And Dr. Mims is a strong supporter of education and collaboration in our healthcare community and has always been so kind to offer her expertise. So we thank you, Dr. Mims, for joining us today and for offering this presentation. And I am going to turn the screen over to you.
Thank you very much. Let's see when I have the screen here. It's a pleasure to have all of you joining us today for this call. I hope that it's going to be information that you can begin to use right away with your practices and facilities and groups that you support, because it's important that we all feel comfortable with the current places that we are with quality reporting. So I'm hoping that at the end of this discussion, you'll understand why you should be reporting PQRS, how important it is now and into the future. There are some changes for 2016, so those of you who are on the call who have done PQRS before, there are a few changes that I'd like to highlight, and you might listen out for the different reporting methods. You might choose to change what you've done before. Then I'm going to finish up with the future. There is no more sustainable growth rate, but what is happening next? So I have a polling question that I'd like for us to look at right now. It should be coming up on the right side of your screen. And I'm hoping that everyone will complete this poll. Looks like there are more than 50 of you on this line.
It says, have you reported to PQRS for the 2015 reporting year? Yes or no? And we're going to give everyone about 60 seconds to vote. We do like to have at least 75% of you voting, and you guys are doing a great job, so we are probably going to meet that quickly. Give you just a few more seconds, and then we'll close it out and share the results. So it looks like our results are 41% at yes and 59% at no, Dr. Mims.
Okay, thank you very much. That's really good to know. And, you know, I have a second polling question. Can I get you to read that one now or let that one go live?
Sure. Did you report to PQRS in 2014 reporting year? Yes or no again? And once again, we'll give you guys about 60 seconds to get in those votes.
Appreciate you spending the time answering these polling questions. It gives us an idea who's on the phone and what your background experience is. This will help us tailor the aspects of this presentation that we want to focus in on, because I want to make sure we meet your needs.
Okay, so we've got the results in, and I'm going to share those. And it looks like we are at 54% yes and 46% no.
Okay, thank you very much. So let's see here. This particular slide talks about where we're going in terms of delivering health care. The historical status, which you're familiar with right now. Everything is based on face-to-face encounters. The more people you see, the more you can bill, period. No one talks to one another, so yes, it's fragmented. But the cost of this, we cannot afford to continue at this rate. It's solely based on fee-for-service. But where we need to go into the future is a different approach to clinical care. It should be based on what the patient would want. I don't think they want to get off work, take a couple of hours to drive in, sit and wait for care, when sometimes it can be handled as a telephone visit or email, or really a call or conversation with another member of the healthcare team. So we need to re-envision what the characteristics of the future state would be, and then set up payment policies that will support that. And CMS is planning on doing that. So this is the heads up that things are changing from direct one-on-one patient care to more patient-centered ways of delivering care from a team. And what CMS says is the continuum of doing this. So category 1, which is on the left, is where we currently are now with fees for service. And they envision that there is some quality incentives related to that, such as PQRS. But then as we further begin to link fee for service with quality, we begin to find programs such as the value-based purchasing from the hospital and something called value modifier for physician payments. We're going to discuss those today, and penalties like readmission penalties. And we go all the way over to category 4, which is true population-based care. So me as a family physician and geriatrician, I'm not only thinking and managing the care of the person who takes off work and comes to see me, but I'm managing the care of everyone who considers me their physician, whether they come in for a visit or not. Regardless of what they are being seen for, I can actually care for the fact that they need mammograms and flu shots and outreach and make sure they get those things beyond coming in for a visit with me. This is the future. There are some organizations like Pioneer ACOs and some hospital systems that are close to there now, and so it can occur. And so CMS early last year, Secretary Burwell said, I want to make a goal of moving more of these payments to alternative models. So we're now sitting in 2016, and the goal is 30%. And from their projections, they really think we'll be there because they did hit the 20% in 2015. And then making sure that those payments are tied to value in a tiered fashion, 85% in this year, and that's the value payment that I'll be describing a little shortly. But look, it's going to quickly jump to 50% and 90% for 2018. That's not very far away. And in fact, what you do this year in 2016 is going to impact your payments for 2018 moving forward. Historically, we've had several incentive programs. I've circled the e-prescribing because basically that has ended. But if you look at the legislation that has started these, we go back to 2006, where PQRS was initially begun, then 2009 with meaningful use, and then the value-based payment modifier in 2010. I am going to talk a bit about that because we haven't really discussed it that much, and now it's coming into play, especially with potential penalties. Okay, so penalties for PQRS. Initially, you got an incentive, a 0.5 percentage point in 2013 and 14. Some of you on the line felt that penalty last year of 1.5% because you did not report in 2013. Some of you have gotten the letter about your penalty in 2016 because you did not report in 2014. But these penalties are continuing. So I have another polling question to get your feedback on where you are with this experience. Can you bring up the poll?
Absolutely. Did one or more of your providers receive a CMS negative payment adjustment letter related to Medicare FFS claims starting in 2015? Yes or no? And again, we've got about 60 seconds. Got about 60% voted, so that's great.
And this is, let me know where you are, your incentive for being on this call, because people did get those letters based on what they did or did not do 2 years prior. It's something that you can do now.
So it looks like we are at 38% yes and 63% no, Dr. Mims.
Okay, great. So 38% of you got that letter saying that you're going to have penalties because you did not report in 2014. And so for 2015, it really is not too late. You can spare yourself for those penalties in 2017 by doing your PQRS reporting, preferably by probably a registry method. In 2015, reporting time frame, which is this month, and I believe they just extended it to middle of March. So, Donna, if you can put those dates in the chat line, that would be helpful. So it's not too late for 2015. The big message here. Today, our focus of the rest of this call is going to be on what you should do in 2016 to prepare for avoiding the penalties for 2018. Value modifier. This is another penalty or incentive that provides the clinician with some information and financial benefits for how well you perform. The challenge with this payment adjustment is that it is based on the performance of several factors. One of those factors is PQRS reporting. So for those of you on the line who did not report PQRS, they do not have the information needed to do the value modifier calculation, and so you're subject to that penalty. When they do have the information needed for the value modifier payment adjustment, it depends on several factors, as you see here on this slide. What I want to highlight here is that there really is an alignment. There is some relationship between these three programs, the EHR, or Meaningful Use, the PQRS in the middle, and this new one you're hearing me talk about, this value modifier. So if you look at the EHR incentive program, there are some clinical quality measures that are the same as PQRS measures. So it's helpful if you use those to report PQRS. They will start showing up on Physician Compare, the fact that you're reporting them, and soon, more granularly, how you fared on those reporting. But you can see this gray box feeds into the value modifier payment. That is how they calculate that quality composite score. So if you don't report PQRS, you're missing this whole green side and are likely to not reap the benefits of a value modifier payment, and hence will be penalized for it. So it comes from a lot of information. They look at cost of care, they look at other types of claims, and they build this whole composite score that is made available to you in your quality and resource use reports, or QRUR reports. If you've not looked at your QRUR reports for the full calendar year of 2014, it is available. You want to know how your cost of care compares to your peers, because that's how they determine this value modifier. So the value modifier payment is based on the size of your organization. So those of you who are in groups of 100 or more eligible practitioners, you began to feel the adjustment of the value modifier in 2015. Those of you who are in the groups of 10 to 99, you can feel an upward payment adjustment in 2016. And if you do not report PQRS, you will get that negative payment adjustment for PQRS. But what you do now will make a big difference for 2018. So it's reporting your PQRS now and doing well on that reporting will impact your penalties or adjustments for later years. And in case anyone is asking, yes, all of these slides will be made available. So I hope I've convinced you that you do want to report. Who is your eligible professionals? Under your tax ID number, it's important to look to see all of the people who are being billed for Medicare fee-for-service under your tax ID number. You may think it's this first set of people, but then when you get your reports from CAHABA of your summary bills, you might find there's a few other eligible practitioners you didn't know about. Once you know who they are, you want to look at the list of PQRS measures, and those PQRS measures are specific to a specialty. So you want to look at all the ones that are helpful for that specialty, whether it's the radiologist or the pathologist or the primary care physician, the surgeon, the ophthalmologist, the nurse anesthetist. Whichever specialty is billing under your tax ID number, you do want to determine which measures are specific for them. Then determine how you want to report. And again, if you have not yet reported for 2015, you still can. And Donna has put the deadlines in the chat box. Registry would probably be the best bet if you have not already reported. You do need to have access to looking at your data and uploading it, so you should secure yourself an account. And then go back periodically over this next year to see what your feedback reports look like. As I said before, you can look at your full calendar year 2014 QRUR report at this time. So these are the eligible practitioners. Practically anyone who can bill Medicare is now considered an eligible practitioner for 2016 reporting. And without reporting will be then subject to penalties if they fall under your tax ID number. Now, when we think about the PQRS measures, there are many, but they fall into these 6 domains. And I like the fact that these domains really do emphasize our patient-centeredness in care. And so all of them will fit into one of these 6, but you only need to report on 9 measures across 3 domains. So that's the usual way we'll be talking about it. Think of it as 9 measures for the calendar year across 3 domains. Now that is a change from before based on certain specialties. Some specialties did not have to report on a full calendar year years ago. Some did not have to report on 9 measures years ago. But it's 9 measures across 3 of these domains is what the current expectation is. So let's go back to the basics. What is a PQRS measure? It actually is a fraction, a numerator and denominator. And so looking at the bottom, the denominator is the number of people in that population that this accounts to. The people who are between ages 18 to 75 that you saw and billed for their service. Whereas the numerator is the reporting that you will do on each claim when the patient is seen of a quality data code, an additional code that you're adding to each claim for the people that you're seeing in the denominator. And I'll make that more clear. Look at this. This is another way of expressing it. The denominator are your billing codes. And for each one of the measures for PQRS, it will specify which billing codes are specific to that measure. So this isn't all of the billing codes. It doesn't cover everything from a surgeon to primary care to mental health practitioner. It's not all of the codes here. So it's important to determine which billing codes go for each measure. The numerator will be those specific codes that you would add based on the measure. So whether the measure is hypertension control or diabetes control or follow-up after hospitalization or medication reconciliation, how one performs on that measure will be the number that you'll put in the numerator. And so it becomes a fraction. So 2 over 10, 20%. So they'll be able to determine how well you're doing with this. So let's get an example of what an actual measure looks like. I want to walk through this because they all are laid out about the same. They're available now on the CMS website. And let's just walk through an overview of what a measure looks like, because for all of the people you're submitting reports for, you want to look at and read and become familiar with each one of these measures. Now, the first top box in the gray, it talks about measure number 1. That's the PQRS number, but the National Quality Form, which is one of the measure stewards, they have their numbering system, so that's NQF 59. Then it'll talk about the title of it, diabetes, hemoglobin, A1C, poor control, and which domain, because remember I said it had to fit within 3, we had to choose 3 domains out of 6. Well, this domain is effective clinical care. Next, it will tell you which year, because there was a whole set of these for 2015 and one for 2014, and they slightly tweaked these, so this is the revised current set for 2016. It's important that you make sure that you're looking at the right ones, and this one I'll be giving a demonstration of is for individual measures, not group. It's specifically reporting by claims or registry. So it's important that you're looking at the specifications for the group that you're targeting. The next part of this will be the description, a brief description of the measure, which would tell you who is the target audience. And it says here, people who are 18 to 75. And we're looking at their diabetes control by a specific lab test to see if it's above 9%. The instructions are very important because it'll tell you how often you need to report this measure. So this particular one says that you have to report this a minimum of 1 time in a reporting period. So the reporting periods are often the year, but it'll tell you if you only have to report it once, or if it has to be reported every visit, or if you report it more than once, which value will be used. So it's important to read these instructions because it'll tell you key information that will impact how you will input this into your system. So you want to know which ones need to be done every visit the person comes in, or only once, and then you never have to worry about it the rest of the year. They describe how you would do this for claims versus registry, so you would want to pay attention to which based on your reporting method. And then it'll specify the denominator. Denominator has a couple of parts. Number one, the age. And since these are Medicare claims, they will know what the age is of the person. Number two, the diagnosis. And as you see, we are now in the 2016 description, so they only are describing ICD-10 codes. And then the fact that you saw them. So we got their age, we got their diagnosis, and you build on a specific date that they were seen. And so the only people who can use this particular measure code are those who have one of these billing codes. I'd venture to say that probably maybe general surgery or ophthalmology, their codes are not down here because we would not be expecting them to be tracking and following hemoglobin A1C. So that would not be one of the people on this list. So this is the denominator. The numerator is a measure or a code that one would put based on whether or not the person's under control. So if we look in the middle of this page here, it talks about if the person's hemoglobin A1C was over 9, you would put the CPT code 3046F. So you would report that along with your claim. Or you have the option of reporting if they did not perform a hemoglobin A1C, 3046F with AP. Now, since this is quality data, we have the option of providing even more richer information, not just that the test was done or that it was above 9, but you see at the bottom there are 2 more codes that gives you what range that hemoglobin A1C is. Is it below 7 or is it 7 to 9? So think about this quality measure code. A PQRS is giving data to the customer, Medicare, not only that you saw them, which is a billing claim, not only their diagnosis, which is diabetes, but now I've added an additional code, a QDC or quality data code, that tells my customer, Medicare, about the status of my care for managing their patient with diabetes. Okay, so now that you're moving forward with selecting your measures, consider the conditions that are usually treated in this clinical practice. Are they chronic care? Do you do preventive screening? What is the location? Is it, are you reporting from a hospital, and so you have practitioners that are under your tax ID number that are from the emergency department? Do you have some from other ambulatory surgical suites? Understand all of the practitioners under your tax ID number, and then go back and find where they usually provide care and which types of services they do as you're trying to do this. When you go back and look at your QR/UR reports from 2014, you may find areas that you've had some deficits. Or when you do some initial data pulls of your quality measures, you may find some areas that you'd like to improve. And these would all be helpful for your quality improvement goals for this year. So there are many reasons for pulling these measures. One is your reporting to Medicare, but there also are a report card for you personally to determine where to focus your quality activities to improve the care that you're giving within your facility. So CMS has put together a grouping of specialty codes by most specialties, and you see primary care and other specialties all listed here. These are hot links. You can also go to the website and click on these, and it'll come up with the 9 or so measures that are relevant to that specialty. It'll also include what we call cross-cutting measures that are very helpful to know, because everyone has to report at least one of these measures that are relevant for almost any patient seeing any physician. So an example of a cross-cutting measure would be weight, BMI. Another example is tobacco cessation counseling. Yeah, I know that's important for primary care, but if you are a surgeon or a nurse anesthetist or a psychiatrist, those are still important ones that you should consider too. So now let's get into what's happening here for 2016, and I've divided this into 2 areas. One will be on individual reporting, and the second will be on group reporting. So in individual reporting, you still have these methods that are listed here, and I'll touch on them one at a time, because sometimes some of you on the phone, this is the first time hearing this. So individual reporting, that's what we're starting with, and we're talking about claims. Now, if you on the phone did individual reporting through claims last year and want to do that again, there is no change. Do it exactly the same as last year. You have to report 9 measures across 3 of the domains, and it has to be for at least 50% of the Medicare fee-for-service patients that you see. So, you know, granted, we didn't get started in January on this, and maybe we won't get started in February, but through the course of the year, we want to make sure that we do this reporting on at least half of the Medicare fee-for-service patients that we see. So we still have time to get started. But if you wait till the second half of the year, you're less likely to still see 50% of the people to report on. So it becomes a little iffy about reporting claims as you go further into the year. So more importantly, I had a person call me and they said, well, we have 3 physicians in our practice and only one of them primarily sees Medicare. Well, the question is, what about those other 2? If they had at least one Medicare face-to-face encounter that they billed for, they have to submit at least one cross-cutting measure. So even though there may be low volumes, the way you're setting yourself up for future payment penalties, you still need to report. And so I showed you before on that diabetes measure that suppose you can report that the person did not even have the hemoglobin A1C measure done. Well, you could report that, but the performance is 0. And so that's not going to help you when it comes to value modifier. Okay, our next reporting method is registry, or a group via registry. And this is a very popular one. And those of you who have not yet reported for last year, you can still do this one now. And Donna had put in the chat box the dates because they've been extended to March. Some of the ones that you can use as these are commercially available. The average cost is nearly $300 per practitioner that you're reporting for, but a measure group is a good way to go. So it's still 9 measures across 3 domains, and it's half of the patients that you see in Medicare fee-for-service. But if you think about you doing a registry, this is even more desirable. Because if you take a measure group, which is usually one diagnosis, like diabetes, for instance, or some behavioral health diagnosis like dementia, for instance, you can report on only 20 patients. 20. Not everybody that you've taken care of for the whole year, but you can retrospectively do this on only 20 patients that you've seen over the year with that diagnosis by that physician. 11 of them have to be Medicare Part B, fee-for-service, not Medicare Advantage, fee-for-service. And so this is an opportunity that makes it fairly simplified to be able to report. Some of you may choose to go this direction going forward rather than claims. It is a simplified way to do it. And if you do it early enough toward the end of the year and not into January, February like where we are now, many of the medical societies have this option available to you at little to no cost. Next one is the EHR. There's some great electronic health records out there that will do your reporting for you, or you can work through a data submission vendor to do it for you. It's still the 9 measures across 3 domains, and at least one Medicare patient data is required. But not every electronic health record has this capability. It has to be a certified EHR, and they have to be listed on the list on the website from CMS and ONC. So if you're using an electronic health record and you believe that yours have that capability, go check the website and ensure that they are certified. They reach this level of certification that will count for you. You don't want to depend on it all year and then find out that yours was not certified. Okay, the qualified clinical data record. So this is, again, another way of doing electronic submission. As 9 measures across 3 domains, and half of them have to from the eligible practitioners Medicare fee-for-service. So that's very important that we consider doing this. A change here is that 2 of them have to be outcome measures. And we'll talk a little bit more about those outcome measures as it's noted below. And those are things like resource use, experience of care, efficiency and appropriate use, or patient safety. And oftentimes these will come through surveys like the CG CAPS, which I'll talk more about. We've talked previously about individual reporting. We're going to shift now to those group practice reporting options, or GPROs. Many of you on the phone might be representing GPRO options for reporting. So let's spend a little time about doing this. Some of you said that, we did 1s and 2s before because we didn't get a chance to nominate ourselves as a group. Well, now you have a chance to do this. So let's talk about these different options. As you see here, there's several programs that are available for you to report as a group this year. But let me call attention to one factor about it. So the clinical or group consumer assessment for providers and systems, or CAPS, is a survey that is done through a specified vendor, and it surveys your patient's experience with your care. It is optional for smaller groups, 2 to 99, who are using a QCDR or qualified registry. It's also optional for the larger groups, 25 to 99, if you're going to be submitting through a web interface. However, anybody who is part of a group of 100 or more, you have to do the CAPS along with your PQRS reporting. So that is a requirement. So if you want to do reporting as a group, you have to register as a group, and then there's some differentiation as to which of you have to report with the CAPS, and I'll describe that in more detail with the different reporting options. So starting with the group reporting option, the web interface. And this is divided as to whether or not you are the size of a web interface that you do not have to report CAPS, or you're large, like over 100, and you are reporting your CAPS. So if you're not going to report CAPS, you have to report the first 248 consecutively ranked patients. So everybody who is on that list, you have to report all of their measures. So if I'm a, 58-year-old woman, I should have measures on BMI, tobacco cessation, medication reconciliation, maybe colon cancer screening. I might be depressed. It's a whole lot of measures that would particularly apply to me. So in this setting, you would have to report on all measures on those 248 consecutive patients. But with this web interface, you probably have the electronic techniques to be able to do this. Now, another option is that if you want to do CAPS. So if you want to do CAPS, yes, you still report on those 248 patients, all of their measures, but you also are submitting caps, which will be important if you're over groups of 100 and you choose to do web interface. Another one is a registry. Again, are you doing caps or you're not large enough that caps is required? So at the top, if you're not reporting on caps and you're doing a registry, you do want to do the 9 measures across 3 domains. Now, if you don't quite have 9 measures for your group because you're a specialty group and you only have 5 measures, make sure you report well on all of those measures. Because if there were some measures that you could have reported on and you didn't, you'll be subject to what we call a measure applicability validation, or MAV. I have a special slide on that. But if you're not reporting all that you're supposed to do for registry, whether it's group or even individual, you're subject to this validation to determine if you really should get penalties. Now, if you are a group over 100, for instance, and you're going to be reporting caps, you don't have to report on 9 measures. It's only 6 measures across 2 domains. So you get a little bit of a decrease there. Now, you do have the EHR direct submission vendors. Some of you are on Epic and then chose to use this as a method, or you're on Aprima and you like that one. Many of them can do that for you. And again, it depends on whether or not you are subject to using caps or not. If you are over 100 and you do caps, you only have to report on 6 measures across 2 domains. So the QCDR for a group, what's new here is that you can do it for groups smaller than 100. It can be as small as 2 eligible practitioners to use this methodology. And these organizations that can do this, Qualified Clinical Data Registries, or QCDRs, are certified by CMS and are on a website. We will be able to post the web link for how you can determine which QCDR to use for this, but it's worth looking at. So the reporting period is through the entire year. If you're using a QCDR, it's no longer a shorter period of 3 months or 6 months or 9 months. It actually is the entire reporting year for this methodology. So be aware of that if you choose to use that going forward. If you're going to use caps or not, it then talks about whether or not you're doing the 9 measures or these 6 measures. And again, these slides will be available for you. I wanted to get to this slide about the MAV, Measure Applicability Validation. What does this mean? Well, so you're an organization and you have several different people who are reporting under your tax ID number. And you have some of them who are specialists and some are primary care. And you've determined that for some of those people you'll report registry and some of those you'll report individual measures. But you had to have 9 measures across 3 domains for these people. Well, some of them you say, well, Dag, this specialty practice is such that all I can report is 3 measures across 2 domains. And that's all they see because it's a specialty practice and that's all they can do. And let's say let's say OBGYN, they really only deliver babies, so we can't submit many of these others. Well, what Medicare will look at is the patient's age, your specialty, and their entire list of measures. And if they see your CPT code on other measures, that means you could have reported on those other measures, like weight, BMI, smoking cessation, tobacco cessation, reconciliation of medications. So just to say that I have this narrow practice and these are the things that are relevant to me, and so I'm not going to report more than 3 or 4 or 5 or 6 when CMS will run its report and say that, no, you could have reported on these 3 or 4 more others, then that means you have not successfully reported PQRS and will be subject to the penalty. So be aware of the MAV. So if you have 2 or more providers or you're solo, this is what you should do. Number 1, go back and report 2015. Number 2, decide how you're going to measure and pull down those actual sheets and read what the measure says. If you're going to submit as a group, you need to register as a group before June 30th, 2016. Go back and look at your prior performance. The whole year of 2014 Quality Resource Utilization Report, or QRUR, is now available, and it figures into calculating your value modifier penalty. There'll be some updates as things go along, but keep this in mind. It's very important. So to be successful, you really need to do this as a team. Many of you are on this call by yourself, and I hope that you don't have to do this work solely by yourself, but enlist some more people to help you do this. When you determine who are the tax ID numbers for the specialists or clinicians that you're reporting for, check out their websites, because they'll tell you, which measures they recommend. And I had that slide earlier that had several of the specialties available. If you did not see one of the specialties listed on there, then they don't have a group that's already on the CMS website that's recommending which measures are for them. You want to check with their specialty instead. So look at your feedback reports, find out who's reporting under your tax ID, pull out those actual measures and read them, have the clinicians read them because they have to do the appropriate documentation should this ever need to stand up to an audit. And so look at your reports. So I told you that I had a special treat for you. No more SGR, sustainable growth rate. But what does this mean? I have a final polling question before I go into my last couple of slides. Can I get the polling question to come up at this time, please?
Absolutely. It says, are you ready for MACRA? Yes or no? We'll give everyone...
So MACRA.
Go ahead, I'm sorry.
So MACRA, that's an acronym that you may or may not be familiar with. Are you ready for MACRA? Yes or no? There is no more sustainable growth rate. SGR has been repealed. Woohoo! But do you know about MACRA?
So we'll give everyone about 10 more seconds. We've got about 60% of you guys voted. And we'll close it out and share the results. We have 13% yes and 87% no, Dr. Mims.
Okay, well, I'm glad you're on the line because you need to know about MACRA. The Medicare Access and CHIP Reauthorization Act of 2015. Remember, they repealed SGR, the Sustainable Growth Rate. Woohoo! It's been around since 1997. But what they put in place was a new fee schedule, and the bill was called MACRA. This will be the new way payment from Medicare is going to be starting 2019. It's going to have two different payment systems, the Merit-Based Incentive Payment System and the Alternative Payment Model, or APM. So starting 2019, you're going to be under MIPS or APM. So yes, SGR went away, but what did it put in its place? This. First, the fee schedule updates. Remember, SGR was saying that we're suddenly going to have these reductions in payment. But no, with this, it says for the first 4 years, you'll get a fee update of 0.5% each year from 2016, 17, 18, 19. But then then it'll be flat. It will be more based on whether or not you're in MIPS or an APM. And the amount of penalty varies between the two. And you see here, there is no third option. You're either in MIPS or APM, and I'll describe those in a few minutes. But the MIPS, as you can see here, there's a payment adjustment that's either positive or negative, from 4% going as high as 9%. Whereas the APMs, it's a 5% incentive payment, unless you then are excluded from it and have to be in MIPS. But if you're successful in qualifying as an alternative payment model, APM, 5% incentive and excluded from those penalties of potentially MIPS. So that's great. So what are we talking about here? So these separate things of PQRS, value modifier, meaningful use, will sunset December 31st, 2018. People going, woohoo, hold up. Starting the next day, January 19th, we're now in the mode of MIPS and APM. As an eligible practitioner, you can be in either or. As I said, MIPS can be positive, negative, or zero. And APM, if you meet criteria, you can get up to 5% for 6 years. What's the catch? So MIPS, the Merit-Based Incentive Payment System, it incorporates the programs of PQRS, meaningful use, and value modifier. I told you it sunsets. They do sunset, but now it's coming in a different name. So MIPS has 4 categories: quality, PQRS, resource use, value modifier, electronic health record, meaningful use. As you see, it's still there. But look, they added something new: clinical practice improvement activities. We don't know what that is yet. That's yet to be determined, and we'll learn soon. We're expecting sometime in March the first things to come out about what that may look like, and there'll be an option to reply and give feedback to CMS sometime in March when we first see some of these clinical improvement activities. You might want to participate in the discussion. You can opt out of MIPS. MIPS is not a requirement. You can instead be part of an alternative payment model. But if you stay in MIPS and don't become part of an alternative payment model, it can be up to 9% of your payments at risk in the near future. So what is the other alternative? This alternative payment model thing starts in 2019, a 5% incentive payment, wow, for 6 years. Oh, that's great. So this is for groups who are qualified. The money is paid in a lump sum on a yearly basis, which is great. And if you get it, you're excluded from MIPS, which I just described. There are criteria to be in an alternative payment model. You have to be in an eligible entity. So some of those eligible entities or definition of an APM are those innovation projects. We really don't have much of this happening in Georgia, though. Or a Medicare Shared Savings Program, Accountable Care Organization, i.e. ACO, or some other demonstration projects. So here in Georgia, most of you in Georgia listening to me today, you get to opt out of MIPS if you're in an ACO. So some people are saying, well, this sounds like Medicare is shifting more people toward ACOs. That is one interpretation, but it's also saying that you don't have to be an ACO. You just have to then work with MIPS. So what is this Medicare Shared Saving Program? It establishes financial accountability and quality that you have to be responsible for. So not only are they looking at those 5,000 beneficiaries, Medicare beneficiaries among this group of providers and how much they cost relative to their peers, and you can get ideas of what your cost of care is relative to your peers by looking at your QRUR report. You can be at financial risk or get a bonus. So there are some possibilities of what you can do here. So I would say, think about this. It is the direction for the future. And if you need help about anything that we've described here today, there are multiple resources that are on here. The Quality Net Help Desk is by phone. They even have an email address. There's several websites that has more resources on it. And then specifically, if you're on an EHR incentive program, you want to know more about the value modifier or ACO, there are those resources here. I know that this was an acronym-heavy discussion we've had today. And so I thought I would list this up here for just a few seconds in case you wanted to look up one or two that I had mentioned. I'm going to leave as my last slide this one. We are Alliant Quality, your quality improvement organization that is here to help you out with these free resources. Right now we are recruiting for practices who want to join our efforts and receive all of our free support, PQRS reporting, improving quality measures. If you would like to join us and have primary care physicians in your group, just send me an email. We're currently recruiting people from our behavioral health initiative. And if you go on our website at Alliant Quality under behavioral health, you can join us or you can send me an email. So with that, I'm just going to go turn this back over to the rest of the team to take it over from here. Thank you very much.
Thank you, Dr. Mims and Alliant. We really appreciate the detailed presentation. And oh, can you imagine if you missed this information today? So thank you, learners and audience, for being on. I do want to remind you guys that I didn't say at the beginning, the handouts are in your dashboard under handouts. You can go ahead and print those out right now. But again, I'll be sending a link in a week for the webinar recording and the handout. Donna, I just wanted to touch base with you to see if there's any comments that you wanted to make regarding the questions and answers. I believe you've been answering as we've been going along. Just checking in with you to see if there's any comments from your end.
Donna, you on mute?
Can you hear me now?
Hear you.
Okay, great. Yes, I have answered a couple of questions. The question was, how do I set up an EIDM account? And I have put a link to the CMS website on how you can do that, as well as updated the time frames for the PQRS submission, the EHR, as well as the Qualified Clinical Registry. Those timelines were changed from the end of February to the middle of March, so that information is in the question and answer session as well. Thank you.
Great. I am going to, thank you, Donna. I'm going to turn this over for a moment to Carmen Hughes to give us a quick update on meaningful use attestation deadlines. There may be some of you guys that want to hear that. Carmen, let me go ahead and show my screen. Hold on here. Are you there, Carmen?
I am here. Thank you very much. Dr. Mims, thank you so much for the great presentation. Very thorough and certainly described all of the requirements for PQRS, and I appreciate the encouragement for the folks on the phone to participate and submit their data. So great information, and you are the technical resource and expertise in that area, so we greatly appreciate it. And Donna, you're answering those questions via the chat are also awesome. And I think one of the questions was around the data for meaningful use. So the quick update is very helpful. We're using your slide. Is that correct, Sherry? You're driving?
I have it on my screen.
Okay, awesome. I see it. So along with the information that Dr. Mims presented, as we move into MACRA for 2019, we're today focused specifically for reporting for 2015 program year for the incentive programs, both Medicare and Medicaid. And so I thought rather than me just talking about it, having this visual in your packet that you can download will be extremely helpful. As Donna mentioned, the program year for 2015 attestation deadlines for both eligible professionals and eligible hospitals and critical access hospitals has changed. It was originally ending the deadline February 29th, midnight. The new date as of this past Friday is now March 11th for Medicare. Still using a continuous 90 days for program year 15 from October 1st, 2014 through the end of last year, December 31st. That is the time frame for eligible hospitals and critical access and rural hospitals. For eligible providers, the deadline for attestation is still or has been moved to March 11th, so that's consistent. But your 90-day period for professionals is January 1st 2015 through the 31st. So any 90-day period during that time frame. It doesn't have to be a particular quarter. It's just any day, any 90-day continuous period. So just want to let you know that we just got the information last week of the new attestation date. The Medicaid incentive program, of course, you know, it's always state-run, and so they have actually. Thank you, Sherry. They have some updates that they have to make. The MAPR system must be updated before you can attest for meaningful use. However, EPs can go ahead and submit their program year 2015 AIU attestations into MAPR right now. So if you haven't already submitted your program year AIU, if you've never submitted before, and this will be your first Medicaid Incentive Program attestation, that would be AIU, so that's program year 1. That application is due now, is due on March 31st, and it's available now. The system at this point is scheduled to close for AIU on March 31st, so it must be submitted within that time frame. Duly eligible hospitals have until March 31st to submit their program year 2015 MAPR attestation, their attestation. So very important. Those dates are consistent for March 31st. If there's any changes, we'll be sure to notify you. Now, please note, I want to make sure that some changes for MAPR have to be made related to the new modified stage 2 requirements. And so therefore, meaningful use applications for program year 2015 are not being accepted, and the system probably will not be available until early third quarter 2016. And these are specifically information from the Medicaid website and the Georgia Department of Community Health, the Health Division. So if you have any questions, I have some resources on the next slide that you can refer to. So again, the Medicaid application for meaningful use will not be available until later this year. Okay, Sherry, I think we're ready for the next slide. Real quick, the hardship application submission for program year 2017, or to avoid penalty for, in 2017. The hardship applications are due by March 15th for eligible professionals, and for hospitals, that's going to be April 1st, 2016. On a note of that, particularly, if you have previously attested and received incentive payments under the Medicaid program, but you may not be able to meet them, the requirements for program year 2015, please contact, and I'm going to say your Georgia High Tech representatives. So that could be someone at Hometown Health, it could be one of our field folks, or directly to Georgia High Tech. Please let us know. And so what that means is, as we know, as I just mentioned, the program MAPR system will not open until the end of the year. So if you received a prior attestation but feel like you may have some requirements for Medicare, you may have penalty requirements coming, we ask that you contact us, because Medicaid will work with us to make sure, or hopefully make sure, that penalties will be avoided. I know it's a bit complicated, but it's important information to know, because we want to make sure that the system, DCH wants to make sure that the system is appropriate for you to avoid any penalty for program year 15. So you may need some assistance with your hardship exception applications. But those are the dates. I've listed some resources here for you as well. The CMS website will give you all the guidance you need related to your Medicare attestation. The DCH website will give it information related to any Medicaid incentive program application attestations. And of course, Georgia High Tech information is here, and as Sherry posted earlier in the presentation. As well as you have Georgia High Tech representatives that you may work with directly, and please reach out to them as well, and for further information, or call our call center.
Okay, thank you, Carmen. Thank you, Dr. Mims. Thank you, Donna. Thank you, Carmen, for communicating that as well. I think the main thing is contact us. And I just want to let you know that Desi has put those 2 meaningful use attestation deadline slides in the handout section as well. So those are there for you. Again, resources will be available in a week. And I'll send you the link. Okay, if anyone has anything else, I believe that concludes our session for today. Thank you all for joining us. Thank you all. Have a wonderful day and a great rest of the week. Bye-bye, everyone.